terms of this presentation, I have no specific disclosures to make. So, a little as others have said, a little bit of what you fancy is good for you, and too much of it is bad for you. None of us want to end up with a liver like that, but I have to be honest, a little bit of this or a little bit of that, it's okay. And maybe really, that at the beginning of my talk is how I'd also like to end the talk, that we have to have a balanced view of the world, and we can't say nothing or everything. The next thing I'd like to just talk about is to say that liver failure is a very heterogeneous group of patients, and it's beyond the remit of 15 minutes to talk about all of them. But these are perhaps the categorizations that one would use. There's the acute liver failure group, the chronic liver disease group, the hepatectomy trauma group. And I'm mainly going to concentrate, for the sake of fluids, on the chronic liver disease cohort, because that is where the literature exists. But one mustn't forget the other group and the fact that the fluids that you might give might be subtly different. So fluids and liver disease generally. Well, my personal view is 5% dextrose is fluid of the devil. It should rarely, if ever, that is probably one of the if ever given in someone with liver disease. You render them hyponatremic almost by definition. They already have brains which are inflamed and at risk of edema. So a lot of what we heard in the earlier presentations might well relate to this cohort of patients as well. So avoid inducing hyponatremia, but also avoid inducing hypoglycemia, and the use of dextrose and insulin to maintain normoglycemia is important. They do sometimes need crystalloid solutions because they're encephalopathic and they won't take in fluids, so you do sometimes have to use maintenance fluids in this cohort. And then we can talk later about the various colloids that one may or may not choose to use. As you develop cirrhotic liver disease, you develop interesting hemodynamics. So basically, your liver is cirrhotic, your central blood volume starts depleting, and your blood volume in your abdomen, your splanchnic blood volume, starts dilating. As part of that, you start retaining sodium and water, you develop ascites, and there is a vicious cycle that develops. So total blood volume is indeed increased, but central effective blood volume is decreased. And in that regard, they're a fascinating group. And one needs to be very sure that when you're giving the fluid you may choose to give, that it sits within the central blood volume and doesn't sink immediately into the abdominal blood volume. The acute liver failure patients, you can almost say, as they come through the door, they are volume deplete, and you will need to give them fluid. They're also the group that we would probably give hypertonic saline to maintain their sodium. They are at risk of gut edema, pancreatitis. They develop a very stiff liver, so very quickly they will start developing ascites as you give them fluid and looking like a cirrhotic, and their guts become edematous and they translocate. The other group, just to mention quickly, are your liver resections, where our surgical colleagues get ever more aggressive and cut ever more liver out. And this is on a very fatty liver. If you give them too much fluid, you will contribute to a small for size syndrome. So you've got all your portal venous blood coming into this tiny little liver segment, and it can't get out. One, because there isn't enough hepatic venous drainage, and two, because your right-sided pressures are increasing and swelling your liver. You then get liver cholestasis, jaundice, ascites, and the typical post-surgical patient, which upsets intensivists and surgeons alike. Now, the cirrhotic population. And excuse me going back through all of this, but it does get important for when we're going to give fluids or not give fluids. You can divide cirrhotics almost into three groups. There are those with ascites and central hypovolemia. They've read the textbook. They're right, all their volume sitting in their splanchnic bed, nothing in their central blood volume. But then there's these other groups. Group 3 is also quite well described. They're the ones with portopulmonary syndrome, high pulmonary pressures. Their right heart is still working, however. There is then this other group, though, and we contribute to it sometimes, or they present as it, and they have right ventricular volume and pressure overload, but they don't have true pulmonary hypertension. And that's the one situation where we need to get out our pulmonary artery catheters and measure transpulmonary gradient, because otherwise you can't separate pulmonary hypertension from volume pressure overload. Really important group. If you give these fluid, you make things worse, dramatically so. I'm going to move on. Otherwise, those gentlemen will be coming to visit me. So you've got this tense abdomen. It affects your cardiovascular parameters. And interestingly, I draw your attention to this. Survival of hospital cirrhotics is very much dictated by BNP on admission. That looks at your right ventricular function and how much stretch you've put on your right ventricle. So again, a bit of fluid is good. If you start stretching your right heart, your liver will get worse and your patient will die. Passive leg raising. By and large, it's an excellent determinant of whether you are likely to be fluid responsive and to avoid giving too much fluid in any cohort of sick intensive care patients. However, in a cirrhotic, you have a knobbly, hard liver, unlike, hopefully, us. That liver sits on your inferior vena cava, particularly the caudate lobe, if you've got venous obstruction. That means that you give fluid and you increase central blood volume, it then goes into your splanchnic blood volume. You lift your legs up, you hope to improve venous return, but it never gets beyond your liver. So you don't see that effect on central blood volume because the fluid is backed up by a liver sitting on your IVC. So you can't assume that just because stroke volume index doesn't go up when you do passive leg raising, that these patients are volume replete. You need also to look at other parameters. So, draining of ascites. It's been around for a long time. It's very efficacious. It's interestingly associated with increased risk of variceal bleeding. So if you drain this ascites, think about it. You drop intra-abdominal pressure, more blood goes into your splanchnic circulation, your liver is stiff, therefore the pressure in your portal vein goes up, and you're at risk of bleeding. So if you're going to drain ascites, don't just think about repleting volume, but what can you do to manipulate that circulation? If you're draining large volumes of ascites, let's think about this. Over 6 litres is where the literature states it, but none of us actually read the original literature. And if you want to prevent post-paracentesis circulatory dysfunction, which is risk of renal failure, if you give saline, you've got a high incidence of it. If you give albumin, it's much depressed. You see it here graphically. So 20% albumin is probably good if you're draining large volume ascites. It doesn't, however, stop your risk of variceal bleeding. And of course, as your abdomen swells, you develop this increase in your inferior vena cava. You can frequently hit about 20 in your renal veins. And this very nice work from Umgelter et al. Showed that draining this fluid in small volumes, 2 litres, maybe that's all you need, actually improves your renal perfusion. And then you don't need to give volume. You can improve the renal function, you can improve your cardiovascular function, no need to volume overload your patient. This is also work from my colleague, George Ausinger, looking similarly in patients with tense ascites, all on vasopressors with high intra-abdominal pressures, and also patients with Budd-Chiari and ascites and cirrhosis. You can see in simple terms, pre- and post-paracentesis. Post-paracentesis, your cardiac index goes up, your SVRI goes down, your intra-abdominal pressure goes down. It's beneficial. In Budd-Chiari, the similar thing happens. It's good for you. But you can also use terlipressin rather than albumin. And this is some very nice data which is rarely quoted because it's in very small numbers of patients. But this is randomizing paracentesis and terlipressin versus paracentesis and albumin. And they are equally effective. So if you are worried about doing a large volume paracentesis and that the patient is already centrally a bit volume overloaded or at risk of variceal hemorrhage, you can use terlipressin, possibly rather than albumin, or if you're concerned because of the guidance, use it in addition to albumin. The data on albumin is actually scant in the liver literature. It's very small numbers, but it's all positive in one direction. This is the prevention of hepatorenal failure, terlipressin plus albumin versus terlipressin. It appears that the two together are more efficacious than terlipressin alone. So that's the rationale. But it's 20% albumin, not 4.5% albumin. But I would just draw your attention to this. So if you're going to be using terlipressin and albumin, what determines your outcome is whether you respond or not to treatment, not the treatment per se. So you need to look at whether you are responding to treatment, and that is probably what will determine your outcome. Equally, norepinephrine's just as good, pentoxyphylin's just as good, and also a bit of data now to suggest NAC is just as good. But the meta-analyses certainly show that drug plus albumin versus no intervention, that is where your benefit is. Again, I come back to terlipressin. Bit of space, gentlemen. I'll hurry on, I promise you. I can talk very quickly if needed. I like terlipressin in a volume replete patient. I think it's actually quite an interesting drug that we've probably not done enough with in the critical care literature. But this is data in patients with ascites who haven't yet got renal impairment, who might be sitting in your ITU. And if you give those patients terlipressin, you can see that there's an improvement in glomerular filtration rate, an improvement in renal blood flow, and in renal clearances. So it's damn good. Varices. I have lots of blood around me if I'm doing varices. Suffice to say, you need to volume resuscitate your patient, but you must remember that your right atrium is connected to your hepatic veins, is connected to your liver with no little valves in between, which is connected to your portal vein. So the pressure that you exert in the right side of your heart will impact on your risk of variceal hemorrhage. So if you're looking at your risk of bleeding and it is your portal pressure of 20, you don't want to be up there. You want to run them on the dry side. This is someone with a tip shunt with right heart pressures of 20, and you see that you still have blood going through your variceal bed. So you've solved nothing. Keep the pressures down, please. I better run quickly. I'll skip that, otherwise these gentlemen will throw me off. But one of the things I really do want to say is albumin is great, but it's not natural. It's got lots of stabilizers in it. And just maybe one of the reasons it's good is because of those stabilizers. Because this data, again, quite old, quite narrow. It's looking at the effect of albumin with or without the stabilizers on cytokine release from white cells. And you see here, if you haven't taken out the stabilizers, it has a nice anti-inflammatory effect. If you've taken out the stabilizers, it increases the TNF and interferon response. Similarly, this is using a filter to clean the albumin. If you clean the albumin, you increase the albumin binding capacity and you decrease the risk of circulatory dysfunction. So albumin might be good both in a clean and an unclean form. Please don't punish your liver. Don't make it too edematous and swollen. Chairman, thank you.